So as we go through our pediatric cranial examination findings, one of the things that we're going to be looking at are the fontanelles. Are they closing evenly? Are they closing too soon? Are they staying open too long? It's really important that the fontanelles maintain their patency over a period of time so that the cranium not only could expand, but the brain can grow its 101% within that first year of life. So we're looking at the different types of sutures. And what is important for us to understand about these types of sutures when we're making our cranial adjustments, how the sutures actually move. So we have true, false, cartilaginous, and irregular sutures. The true sutures are the sagittal suture and the coronal suture. Both of these sutures are slightly interdigitated. The dentate suture is the sagittal, and the coronal suture is the limbus, also has slightly indentations. So when we think about moving the cranium or making adjustments to these sutures, we have to think about expanding them laterally, expanding them away from their contact points. In other words, opening the sagittal suture and widening it to unhook that suture, and also to lifting and separate the coronal suture from the parietals. It's important to understand that because we don't want to be jamming the sutures. And of course, as we know, in the pediatric cranium, which we're going to be looking at right over here, you can see that this suture system hasn't evolved yet. So we have a window of opportunity of at least the first year up to 18 months where the suture is completely separated and we can make more movements and greater shift within the cranium. Then we have what's called false sutures, which are these are kind of where the suture is formed by a reference surface. And what happens with the temporal bone, for example, the sclerosal suture, is that suture allows the temporal bone to rotate and to flare at the same time. So we think of the petrous portion of the temporal bone as the axle, and then we think of the rest of the temporal bone as the wheel. We can see this suture allows for a rotational component for the temporal bone going to internal, external rotation, and also for the flaring of that suture away from the skull. Then inside the palate, we have these plane sutures. And again, we have the palatine suture, and we also have the intermaxillary suture. These allow the palate to expand and open up. And again, when we're making our corrections, when we think about going into the palate and moving it laterally, we're separating this particular suture. So the reason it's not a real suture is because it's really just butted up against each other, and the bones are basically contiguous to each other. Then we have cartilaginous sutures. These are the most mobile type of sutures. So for example, our sphenobasal suture is a synchondrosis suture, the most mobile suture in the cranium, and it stays a synchondrosis suture for the first 20 to 26 years of life. Then the other is our symphysis, which is a suture here, which is basically where there's fibrocartilage. This is the TMJ joint. So when we talk about the TMJ, there's a posterior disc here and a posterior distal ligament that hopefully stays a suture and stays a joint, a mobile joint or a symphysis type joint throughout your life. This, of course, allows the temporal mandibular joint to go through its three ranges of motion from occlusion to rotation and translation. The other sutures that we look at are these irregular sutures. The symphysis suture is really kind of a hook suture. So we talk about the palate being able to move up and down. One of the reasons that it's important for the palate to be able to move up and down and to go into flexion and extension is because it pushes into the vomer, which is the connection between the cranium and the palate. And as the vomer has to actually slightly unhook, which means it has to move slightly superior and anterior to move the greater wing of the sphenoid, which is why whenever we change or put pressure on the palate to move it, we always press post-superior and anterior and pull slightly, posterior and superior and pull slightly anterior to allow the greater wing of the sphenoid to unhook. And then we have our gumphosa sutures, which are where the teeth come into play against the maxilla. So when we look at this system and we're making our cranial adjustments, obviously as the child gets older and we're dealing with or we're dealing with the adult patient, the sutural formation is going to be much more important because it's going to play a much larger role than it is in the pediatric skull those first 18 months when the fontanelles are still open. Remember, we have this anterior fontanelle, which can stay open for up to 2 years, but somewhere between 7 and 19 months. And then the two fontanelles on the side, the sphenoid and the mastoid fontanelle, the last one to close is the mastoid, which stays open for 18 months, and the sphenoid for about 15 months. So this is the kind of window of opportunity we have to really set up a parameter for cranial growth patterns, which ideally is also the same time frame that we talk about brain growth and development. The first year of life, the brain grows 101%. The next year, another 15%. So we're talking that whole window of 2 years that we speak about so much in our class of how important it is.